Hello, and welcome to the Chest Journal podcast, where each month we host a discussion with the authors of important articles from the current issue of the journal, adding context and commentary to the challenges facing clinicians in the fields of pulmonary, critical care, and sleep medicine. To introduce today's topic, here's your host, Dr. Matt Siuba.
Welcome to this month's edition of the Chest Journal podcast. My name is Matt Siuba. I'm a critical care doctor, medical intensivist at the Cleveland Clinic in Cleveland, Ohio. Today, I have the distinct pleasure to discuss a great, really interesting article titled "The Effects of Targeted Mild Hypercapnia on Right Ventricular Function After Out-of-Hospital Cardiac Arrest, a sub-study of the Targeted Therapeutic Mild Hypercapnia After Resuscitated Cardiac Arrest Trial." I'm joined with two of the authors, the first author and the senior author, Dr. Mathias Melberg and Dr. Eirik Qvigstad from Oslo, and we're going to get to know them here shortly and learn about their work. So, gentlemen, thank you so much for joining me today. Really excited to dive into this article. For the sake of the audience, for the benefit of the audience, could you please give us just an introduction of who you are and where you work?
Sure. Thanks for the invitation. We're very excited to be here. My name is Mathias Melberg. I'm a medical doctor at the Department of Cardiology at Oslo University Hospital, which has two locations, but this is location called Ullevål. And I'm a cardiology fellow and a PhD student.
Hi, my name is Eirik. Thank you very much for the invitation. It's an honor. I'm a senior consultant in a full-time clinical position at the Cardiac Intensive Care Unit here at Oslo University Hospital. I hold a PhD in basic research on inotropic signaling mechanisms in heart failure. And I'm a cardiologist and board certified in internal medicine. So that's my background.
Thank you both. I'm really honored to have you with us today. To dive into the background of this paper, what did we know about hypercapnia and right ventricular function before this study?
Sure. The partial pressure of carbon dioxide in the blood, as probably most of your listeners know, is the balance between the elimination and the production of carbon dioxide. And in most cases in clinical settings, we usually think as the partial pressure of carbon dioxide as the rate of elimination. And hypoventilation causes hypercapnia. And it's important to note, I think, that there's been a marked increase in the incidence of hypercapnia among critically ill patients, especially undergoing mechanical ventilation. And this is probably in large part due to permissive hypercapnia as part of ARDS treatment. And hypercapnic acidosis, as is, of course, follows hypercapnia acidosis follows. The reason that the TAME trial, or the Targeted Therapeutic Mild Hypercapnia After Resuscitated Cardiac Arrest trial, we'll call it TAME from now on, I think. The reason it was performed was that hypercapnic acidosis, it increases cerebral blood flow markedly. And it appears that this mechanism is preserved after cardiac arrest and ROSC. So, and there were some promising observational studies and a phase 2 RCT, which found that NSE, neuron-specific enolase levels, were lower in patients resuscitated from out of hospital cardiac arrest when they were treated with therapeutic hypercapnia, mild hypercapnia. So that set the stage for this very large randomized controlled trial, which included approximately 1,700 patients in multi-centers, several countries. And that trial was neutral with regards to neurological outcomes and was published in the New England Journal of Medicine. But the reason we performed our sub-study is that conventionally, when you think of hypercapnic acidosis, it is sort of commonly said that it increases pulmonary vascular resistance. And it appears, like in most clinical studies that have been performed, that yes, hypercapnic acidosis does increase the pulmonary vascular resistance, and it can also worsen hypoxic pulmonary vasoconstriction. Hypercapnia appears to be sort of unpredictable. It varies from study to study, and most of the data is experimental and preclinical. And it's importantly also to note that it's quite well known that hypercapnic acidosis is a potent coronary and systemic vasodilator. And if you look at patients with RDS, there is quite a lot of data that seems to say that, yes, hypercapnia increases the pulmonary vascular resistance, but cardiac output is often increased due to systemic vasodilation and because you use lower tidal volumes. So that is basically what we know beforehand. That is sort of the gist of what you need to know, I think, about hypercapnia. With regards to RV failure, I think that the presence of right ventricular failure appears to be quite an ominous sign. It's sort of well established that in critically ill patients across many different types of populations, cardiogenic shock, sepsis, ARDS, and also cardiac arrest, the RV failure appears to be associated with worse outcomes. And I think, but a major caveat, which is nice to know, is that there is no sort of universal definition of RV failure, and most studies looking at RV function in cardiac arrest and other critically ill patients, it's difficult to sort of they usually use different definitions, and oftentimes these definitions are subjective. So it is difficult to sort of with certainty to extrapolate and generalize across these different studies and populations.
Yeah, and of course, as he mentioned before this study, the prevailing view was that hypercapnia and the lowering pH increases load on the right ventricle. So the right ventricle especially being sensitive to increased afterload. This might, of course, worsen right ventricular function, and we especially in the vulnerable intensive care patients. And of course, we also know that hypercapnic acidosis has been shown to directly depress myocardial contractility via calcium handling, decreasing myofilament sensitivity. And we also know that hypercapnia can increase arrhythmias through disrupting sodium-calcium balance and so on. So there's numerous effects, and we didn't actually know what to expect when going into this study.
Yeah, thank you for that great overview. I think you hit really all the important background pieces, and you could see how this study, the TAME trial that this study originated from, might seem like we're pitting sort of the brain against the right ventricle or the brain against the heart. So is that kind of what inspired this study question, or is there other things behind it that the listener should know about?
No, definitely, that was the worry. Yeah. And that also prompted sort of the investigation. So we want to investigate the right ventricle. How do we do that? Well, we need to perform right heart catheterization. So that's and echocardiography both, and definitely it was sort of that was the worry. We were worried prior to the trial that the increased pulmonary vascular resistance would lead to would negatively affect RV function. And given that it also appears to be sort of RV failure in the setting of cardiac arrest or after resuscitated cardiac arrest, the fact that it appeared to be associated with worse outcomes was definitely a worry. Absolutely. And also we also wanted, but given that most of these studies that had looked at RV failure and cardiac arrest, they are retrospective in nature. So we wanted to sort of hopefully provide some prospective evidence to this question.
Yeah. We are the largest cardiac arrest center in Norway, and in fact, when we were invited to participate in this TAME study, we were in fact really concerned about the intervention, whether it might have adverse effects on the heart. So we discussed that, and then we decided to come up with this sub-study, really to try to answer these questions, because as to the best of our knowledge, there is very little high-quality randomized data on this, especially from cardiac arrest patients. Most is from studies on acute lung injury, RDS. So there is a lack of good data, we thought. So maybe we got the opportunity to maybe answer some of these questions.
Yeah, that's what I think is so interesting about this study. I was really excited when I, picked up the paper for the first time just to see how rich the data is here, because we have both non-invasive and invasive hemodynamic data. So now that we kind of have this background for the study and sort of some of the key elements of it, could you all give us a basic overview of the study design?
Yeah, thanks. So this was a pre-planned prospective sub-study of the TAME trial, which was an RCT, and the TAME trial, it was an international investigator-initiated open-label trial. It randomized patients in a 1-to-1 ratio to mild hypercapnia, which was a target of 50 to 55 millimeters of mercury, or targeted normocapnia, 35 to 45 millimeters of mercury, for 24 hours starting at randomization, which was performed shortly after the patients were admitted. The patients were comatose adults, and they had to have sustained ROSC, return of spontaneous circulation, for 20 minutes to be eligible for enrollment. An interesting side note on this is that hemodynamically unstable patients and patients who were deemed to be in cardiogenic shock, they were included in the TAME trial, which is a bit different from like the cooling trials or the TTM trials, where people with cardiogenic shock, they're usually excluded. And importantly to note, hypercapnia in the hypercapnia group was achieved primarily by reducing the respiratory frequency and secondarily by reducing the tidal volumes. And importantly also, both groups were ventilated according to lung protective principles, so at least in our center. And as I said, this was a single center trial, so that's important to note, of course. So we wanted to assess right ventricular function. So how did we do that? So we performed transthoracic echocardiography, and it was performed shortly after the ICU admission, during the intervention and after the intervention period, with approximately 24 hours between the during intervention and after intervention. And we performed time-matched right heart catheterization if it was available. So we tried to perform right heart catheterization in as many patients as possible, but it wasn't always possible, which we'll get back to. So, and an important note now is, so how did we define RV dysfunction and RV failure? So RV systolic function, we assessed it with echocardiography primarily. And we looked at the TAPSE, the tricuspid annular plane systolic excursion, the S prime, and the fractional area change. And the patients had to have 2 out of 3 measurements less than the abnormal threshold to be defined as dysfunction. And RV failure was defined as the presence of RV systolic dysfunction, and they had to have a cardiac index less than 2.0 liters per minute squared, and they had to have a central venous pressure above 12 millimeters mercury. And important thing to note here is the central venous pressure. Why above 12? Well, that's based on, of course, previous data and previous studies as well. But in our mode of treatment, the way we treat these patients, the target central venous pressure was between 8 and 12. So we very aggressively try to treat the central venous pressure. We place a central line or a right heart cath on every patient. And so if we can't get the central venous pressure below 12, that's a very clear indication that there is a backward failure from the right ventricle. And we performed survival analysis. We used Cox proportional hazard models to do this, which were adjusted for common confounders. So I think that's an overview. Is there anything particular you want to ask regarding this?
No, thank you for that. That's very helpful to have both the details of the timing and the definitions, both the invasive and non-invasive. So now that we have sort of outlined of what we're measuring and when we're measuring it in these two groups, the targeted mild hypercapnia group and the normocapnia group, what were the key takeaways from your study?
Well, I think that the major key takeaway in this study is that mild hypercapnia after out-of-hospital cardiac arrest did not harm right ventricular function, and was actually associated with less RV dysfunction and heart failure, because the prevailing view was that in fact that hypercapnia might cause adverse effects. I think this is really important to stress, and maybe especially regarding current guidelines in ventilated patients, where we try to target normal capnia. And I think the problem is when the challenge is that when we are chasing normal PCO2 levels, we may shift the ventilator settings away from this lung protective strategy, and that might lead to unwanted adverse effects on the lung physiology. So I think that is important takeaway. And of course, RV failure itself, that it predicted mortality, and I think it's really important that we don't forget the right ventricle or the patient with RV failure, to manage these patients that have a higher risk of adverse outcomes. So I think that is the main takeaways.
I think so too. And as Eirik said, there was all the parameters looking at RV function, the TAPC, the S prime, the fractional area change, they were all higher in the hypercapnia group, which leads to think that the RV function was improved. And also the invasive measurements, which looked at parameters that might not be well known to everybody, but you have the right ventricular stroke work index and the right ventricular cardiac power output, which sort of tries to look at the RV contractility. They were clearly higher in the hypercapnic group. I know that perhaps some of your listeners they know the parameter called PAPI, the pulmonary artery pulsatility index, and people like that to diagnose RV failure. And we did not find any difference between the groups for that parameter. But important to note with PAPI, I think, is that it's not really validated for this population. And if the PAPI is below the threshold for RV failure, which is usually below 1.5 or below 1.2, it's usually the central venous pressure has to be really high, and I think some of your listeners might be interested in that. And the right ventricular failure was indeed associated with increased mortality, with a hazard ratio of 2.89. Confidence intervals 1.37 to 6.1, and a p-value of 0.05. So definitely a very statistically robust finding. And I think it's worth mentioning that among all the parameters we looked at that assessed RV function, it was only TAPC that was also significantly associated with worse outcomes when it was low. So with markedly reduced TAPC, there was an increased mortality. But I think that is the key takeaways, I would say.
What I really like about this study is that we used echocardiography and parameters that are able to obtain, and together with CVP from central venous catheter and cardiac output, we are in fact able to identify, after our definition, RV failure, and that is linked to adverse outcomes. So I think it's something that everybody can do bedside. So I think it's really important.
Yes, and importantly, as Eirik said, it's sort of easily available for most clinicians who treat patients with cardiac arrest. So these patients, they usually have a central line, but not all centers might be able to place a pulmonary artery catheter. That's, I guess, that is more rare, I think. But echocardiography and being able to measure a central venous pressure, that should be obtainable for most centers, I think.
Thank you both for that great overview. I just want to highlight a couple of things that you said because I think they're particularly interesting. Though, starting with the last thing is, the incidence of RV dysfunction or RV failure in this study was enough that we should be looking for it in patient and post cardiac arrest patients for sure, but probably our other critically ill patients as well. And there are ways you can do that with technology that most people are already using. When I first picked up this paper, the most interesting thing, of course, was the primary finding that mild hypercapnia was actually associated with better RV parameters, which I think is going to be surprising for many people. But it seems like, one potential mechanism that Eirik alluded to is the fact that maybe because we're using potentially less injurious ventilator settings to achieve a lower PCO2, that might be part of the protective benefit. Do either of you see any other potential hypotheses that explain the differences between these two groups and their RV parameters?
Yes, I can start, Eirik, and
supply. Many.
we do actually, but it's because this is an RCT, and because the sort of intervention is in a way quite complicated. So you're doing something with the ventilator, as you say. You're lowering the respiratory frequency, you're lowering the tidal volumes, and you're also lowering other things. You're lowering the plateau pressure, the driving pressure, while we kept PEEP. The PEEP was similar between both treatment groups. And then you're also causing this hypercapnic acidosis, which has a lot of physiological consequences. So it is sort of difficult to sort of say with certainty what is going on, but it's easy to sort of think in a framework of, so RV function, it's influenced by preload, the afterload, the contractility, the lusitropia or the relaxation, the pericardial constraint or the restraint, and the interplay with the left ventricle. So I can start with the interplay with the left ventricle. So I don't know, it depends on what you read, but like a pretty large proportion of RV function, maybe as much as 30%, 35% of RV function comes from the left ventricle or the interplay with the septum. So hypercapnic acidosis, being a systemic vasodilator, might actually sort of improve LV function, and therefore by doing that also improves RV function. That is a potential mechanism, of course. And of course, ventilator adjustments, lowering the minute volume, the tidal volumes, there is a potential to lower RV afterload. And while the pulmonary vascular resistance, that's sort of the resistive afterload of the right ventricle, RV afterload is surprisingly and perhaps annoyingly complex, where you sort of you also have sort of other mechanisms of RV afterload, which there is an indication that it actually is lowered in the hypercapnia group. So we use the parameter, which is perhaps not that well known, but it sort of can give you an indication. It's called the pulmonary artery effective elastance, and that looks at not the resistive afterload, not the pulmonary vascular resistance, but everything else. And there is indication that was lowered in the hypercapnia group. So there is signs that, but exactly why that is, it's a bit difficult to elucidate. And thirdly, so there is depends on what you like. Hypercapnia, it's unpredictable in a way, but there are. So a large part of the post-cardiac arrest syndrome, or the stunning of the myocardium after cardiac arrest, which affects both ventricles, is due to sort of ischemia and ischemia reperfusion injury. There are experimental models that have shown signs that hypercapnic acidosis can sort of attenuate ischemia reperfusion injury, and so there is sort of at least a theoretical possibility that hypercapnic acidosis sort of alleviates or attenuates this stunning. And I think we can note also that this is completely hypothesis generating, of course, but in our group, in our hypercapnic group, in patients with acute myocardial infarction, the high sensitive cardiac troponin levels, they were lower. And we have published that in a separate article, but it can be nice to know that there is perhaps also some that also supports that theory, but we wouldn't want to sort of say that is the answer. That would be wrong. And of course, the afterload does not appear to be particularly affected by this treatment. So I think that's sort of the main possibilities that we have investigated. Do you want to supply something, Eirik?
No, I think you pretty much said it all. But of course, there are CO2 is really active, physiologically active in a way. I mean, it also can reduce calcium loading in the heart, and that can protect against apoptosis. There has also been shown that increasing PCO2 levels can attenuate inflammatory processes. So there are really numerous effects, and probably this is a mixed effect of many things, but we don't actually believe it that everything here is small differences in ventilator settings. It seems too potent in a way. That's my just guessing.
That was a great overview. I think you both outlined probably a decade worth of future studies when thinking about some of these potential hypotheses that might explain the results. As the readers are going through this paper and hearing what we're talking about, what sort of words of caution do you have for them in interpreting the results in terms of limitations or other things?
Yeah. So of course, this is a small sample size. It's 111 patients with only 84 having a right heart catheterization and 111 patients having an echocardiography. So there is a limitation there, of course, in this sort of in this world, 111 patients is not that small, but I think we need to be cautious about that, the number, and it is from a single center. So of course that also matters. And important to note, we used targeted temperature management. At the time, we targeted 33 degrees. So the patients were cooled, or so that it makes that. So you have to sort of think about, okay, are these results reproducible to patients who are not treated with TTM, targeted temperature management, at 33 degrees? Would it be different if they were treated with fever management or other strategies? Which is, of course, we have to take note of. But I think it's important to note that in most of the hemodynamic sub-studies from the TTM trials, there doesn't appear to be much difference in RV function between 33 degrees and 36 degrees. So you can note that. Of course, the fact that there is no universal definition for RV failure, it sort of course, complicates the generalizability. But hopefully, by using a standardized, reproducible, and sort of multimodal approach, we hope that possibly it should be easy to reproduce, which strengthens the results, I think, overall. And of course, when you look at RV function, one of the big sort of problems with looking at RV is that all our measures of RV function are loading dependent. So we don't really know if for example, if the contractility is improved. To do that, we would need equipment which is not really available in clinical practice. And of course, the TAPSI, when we did echocardiography at admission, circumstances around these patients, they're unstable, they have to undergo procedures, etc., meant that we were only able to do a proper a TAPSI at the admission. So as prime and FAC were not really that available at the admission echocardiography, which is, of course, we would like to have, but unfortunately we don't. And of course, the fact that we only 84 out of 111 patients had right heart catheterization, that of course limits our ability to sort of combine the two examinations. But importantly, the central venous pressure, that that did not require a right heart cath. And we also had to do some statistical adjustments regarding that. Not all patients had echocardiography at the same time, but there doesn't appear to be a large skew towards that. The echocardiographies performed later during the intervention were much different from the others. So all in all, that finding looks robust. And also, if you look at the right heart cath data, you'll see that there is sort of a very sort of the difference. Like if you look at the measurements, the serial measurements of the right heart cath, you see a very clear trend towards that. When you stop the hypercapnia, the curves they meet. So there is a quite sort of a strong indication that this hypercapnic acidosis has a sort of a quite fast on-off effect, which sort of also supports our results, though. But of course, it is a caveat that also only 84 out of 111 patients underwent these measurements. I think that's the major limitations that I think the listeners should think about.
I agree. Yeah.
Great. Thank you. That was very helpful to put this in a further context. To take it even a step further, now that we have the results of this study in the context of the rest of the literature on this topic, how do you think clinicians should think about RV function, hypercapnia, and post-cardiac arrest patients, particularly? And then, do you think these findings actually might extrapolate to other critically ill populations?
Well, that is it's a difficult question. But I mentioned it before that it is recommended to achieve normal capnia with a ventilator. Of course, if you're chasing the normal PCO2 level, that again, it might shift the ventilator settings away from this non-protective strategy. And so by doing that, you might get increased loading on the right ventricle and the unwanted adverse effects. I think maybe we shouldn't be that afraid of mild hypercapnia in also other patients. And I think our findings also support that right ventricular failure is really linked to bad outcomes. So I think it's kind of supports that in this population as well, that this is really, we should not forget the right ventricle. Too often people focus too much again on the left, but the right is also really important. I think that is one thing we should have in mind.
Yes, and of course it's given that most of these patients, they die of anoxic or hypoxic brain injury. It's sort of difficult to be sure if like the hemodynamic derangements, how much are they contributing to the demise of these patients? It's very difficult to know. And of course, but you can look at this in two ways. Okay, so RV failure, are these hemodynamic derangements, are they in some patients responsible for the death of these patients? That might be in select patients, of course. And it also might be that if you see pronounced right ventricular failure in a patient resuscitated from out of hospital cardiac arrest, it should be sort of perhaps a prognostic warning sign that this patient has a worse prognosis. And I think we see this in clinical practice. I don't think it's uncommon that we see patients who have been resuscitated for a long time that they have a really bad right ventricle. So that's and I think I also want to highlight in a way that if you listen to people talk about RV failure and mechanical ventilation, they also say like rule number 1, don't intubate. That's sort of the rules. But in these patients, the cardiac arrest patients, you don't have a choice. They are intubated. And they usually have to be intubated for at least a couple of days before you can extubate them. So when you don't have a choice, how do you handle RV failure? Well, I think perhaps at least you should, there is limited treatment options. So thinking about the ventilator, how do I optimize the ventilator? can I lower the tidal volumes? Can I lower the respiratory frequency? And perhaps accepting that the patients become hypercapnic. I think that is, it's at least wise to consider. But you can't give a blanket recommendation, so you have to individualize, which is an annoying thing to say, but I think that's the best we have.
I'm not sure individualizing is ever an annoying thing to say. I love that guidance because I think realistically we can only we study populations and we treat individuals, and sometimes you say this person doesn't fit into the average. But thank you both. This is such a great overview of a really interesting study, and really want to commend you on this effort. Any final thoughts from either of you?
Well, I have some final thoughts because I know there's been increasing interest for the right ventricle and right ventricular failure, increased interest in recent years. But I still find that the RV receives less attention than the left. Sometimes when I get a new patient, it has been performed echocardiography, and that often failed to really assess the right side. There's a lot of pictures about of the left side, but not too much of the right. So I think there remains a need for greater recognition of the role of the right ventricle in acute and intensive care medicine still.
Absolutely, and I think there has recently been large review articles about RV failure in both New England Journal of Medicine and European Heart Journal. So there is increasing, interest in the right ventricle, which is very, very nice to see. And I think what's often sort of talked about is that, so RV failure, there is not a lot of evidence to guide the treatment here, but understanding the physiology of the right heart and also being sort of able to perform, at least have a central venous pressure, and perhaps also doing a right heart catheterization can help you a lot in treating these patients. And I think, so smarter people than me have sort of underscored that quite a lot, and I think that is true. And I think I would also like to thank the reviewers and the editors of CHEST because they helped us improve the paper considerably. So I think we would like to say thanks.
Yeah, I agree.
Fantastic. Thank you both today for joining us, Drs. Melberg and Qvigstad, to talk about this article, The Effects of Targeted Mild Hypercapnia on Right Ventricular Function After Out-of-Hospital Cardiac Arrest, a sub-study of the TAME trial. Again, thank you both for being here. Thanks to the listeners for joining us today. And most of all, we can definitely say, please pay attention to the right ventricle and also join us next time. We look forward to it.